Hello, everyone. I'm Mohammed Hassan from Chugtai Institute of Pathology, Lahore, and I welcome you all to this online session of Histopathology Outreach Program for All, which is Hope for All. And I welcome our guest speaker, Dr. Rifat Mannan, who has joined us from California. He is the co-founder of PathCast, and he is Associate Clinical Professor of Pathology at City of Hope National Medical Center in California, USA. Thank you very much, Dr. Rifat, for joining us for this session about colorectal polyps. So now you can share your screen, Dr. Rifat, and begin the session. I think you're muted, Dr. Rifat.
All right.
Okay.
Thank you so much, Ahsan, for this kind introduction, and thank you for inviting me to your session. And thank you all who have joined today's session. As Ahsan has said that I work at City of Hope. So this is a cancer institute here. And let me share my screen. Can you see my screen?
Yes, we can see your screen. Yeah.
So today I'm going to talk about colorectal polyps, which are actually bread and butter of any pathologist, whether you are a specialty pathologist who is only doing GI pathology, or you are doing general pathology anywhere else. So as residents, so the moment you are getting out of your residency and getting into practice, so you will find polyps every day. So it's always good to have some basic idea about how to diagnose the polyps. So that's why I thought that I will make it a case-based approach. And another thing that is in my mind today is to keep it interactive. So I will have some simple questions so that you can feel free to answer them, and you can put them in the chat box. So that would be great. And this is the hospital where I work, and you can see the mountains in the backside. And I have no disclosures. So I'm a big fan of Arshad Nadeem, and I was watching it live when he won the gold medal, and congratulations. And I am also a big fan of Pakistani cricket since my younger days. I have watched 1992 World Cup final, and I'm a big fan of Imran Khan, Javed Miandad, Wasim Akram, Wakar Yunis, all of you, Abdul Qadir, all of them. And so Pakistan and India, cricket is in our blood, right? So, but it's good to see Arshad Nadeem, who is winning gold in a different sports. It's really great. So, moving on to our today's topic. So, this is not javelin throw, right? But it is simple. So the brief outline is here that what are the different types of colonic polyps we are going to discuss with examples. What are the diagnostic criteria for the colonic polyps? And it's always good to use proper nomenclature. So that also we will talk about. And some updates on WHO, which is already, since 2009, it is already 5 years old. Maybe new one is coming soon. So still, like, we are with the 5th edition, so we will talk a little bit about how the current WHO guidelines are regarding the colonic polyps. All right. So when we talk about colonic polyps, so this is what we see when someone does a colonoscope, right? They are of different types. You can see that some are sessile, some are pedunculated. And nowadays, endoscopy techniques are very advanced, so they can actually make a good diagnosis of colonic polyps. So based on endoscopic appearance itself, you can see that here, this chromoendoscopy, they can see the vasculature here, right? So you can see even here, the pictures are a little different. And this one already looks like fat, isn't it? So probably this is a lipoma, even without looking at the microscopy. But still, We will talk about the pathologic diagnosis of colonic polyps, not about colonoscopy, but it is always good to know the different correlations between the colonoscopic picture and the histology. So keep that in mind and make it a practice to know how they look under colonoscope as well, not just the histology. That's a good practice whenever it is available. Of course, you may not have the availability to look at the pictures all the time, but whenever it is available, we should look at the colonoscopic pictures as well. So before I move on, I just wanted to make sure, Asan, am I audible well?
Yes, you are very well audible. Yeah.
Okay, great. Thank you. So first one, polyp and hepatic flexure. So one thing I want to emphasize here is that don't go much by the location. So if you are biased by the location, then you will not get a correct morphologic diagnosis. So rely on morphologic criteria. That should be the cornerstone. We will emphasize that again and again. So, but still, you need to know where the polyp is, right? That's important. So this is a polyp in the hepatic flexure. I'm just showing it to you. You know, everybody knows what is this looking like. I'm not going to go into details. This is as a PGY1 first year pathology resident, you see this. You see this all the time. I mean, every day, whenever you're looking at colonic polyps, you will get a lot of these ones, right? So I'm not going to ask you what is the diagnosis. So this is a run-of-the-mill tubular adenoma, isn't it? So tubular adenomas can itself be tricky, but we will not talk about how to diagnose tubular adenomas, so that I am sure you know well how to diagnose tubular adenomas, how to diagnose high-grade dysplasia in tubular adenomas, and things like that. So let us talk more about the adenomas or the polyps other than tubular adenoma per se today, okay? So moving on, so let's see that this is a sigmoid colon polyp. I have got a few slides digitally. Let us see if we work on that. So look at this picture. So this is also a very classical polyp that you see very frequently. So let me show you. This is a low power view, right? Okay. And just a little bit higher power. This is very, very classic, right? You see a polyp like this and you know like what you are looking at, isn't it? So, but if I ask you a question that what is your diagnosis? So is it a tubular adenoma, tubular villus adenoma, hyperplastic polyp? What do you think? I mean, can you put it in the chat box? Maybe I can keep an eye on the chat box here. Anyone? Okay, great. So I see your diagnosis. So this is a very simple hyperplastic polyp. Perfect, great. So another one, descending colon polyp. Let's look at that too. Okay. So let's see if we can do the transition smoothly. Okay, great. So this is a descending colon polyp. Okay. And you can see this is the low power. All right, let's go to a little bit of a higher magnification. So here you can see how it looks like, right? Okay. So this is another higher power view. Okay. Now there is no dysplasia, isn't it? So it looks fine. So going back, I want to ask you the same question. So what do you think of this? Same choices. Anyone? Can I see the answers here? SSP. Okay, someone says SSP. Another? Any other options? TSA. Okay, good. D, sessile serrated polyp. Okay. So good to see different answers. I'm glad that you all are thinking differently. Okay, cool. Some what? Any other options? Tubular villus adenoma, C, hyperplastic polyp. So someone says also that it's a hyperplastic polyp, right? Okay, let's go back. We can look at both the pictures together, right? I mean, I did not tell you exactly like what was the first one. So this was the first one, which everybody knows. Maybe some of you have just joined pathology. I don't know. So like, I mean, it may be the first year of pathology, but for the seniors, you have seen this all the time. This is a very, very classic hyperplastic polyp, isn't it? So hyperplastic polyp is, you know, it is serrated, right? You can see the serrations here. And the type of serration is also important. So you can say that, you know, these are sawtooth-like serrations, right? Okay. And then you see the serrations here are confined to the upper portion of the gland only. The serrations do not go all the way to the base. So that is something very important, as you will see later. And also you see that the crypts which are towards the base, so they are not dilated, right? So there is no crypt dilatation. This is a serrated polyp, and the serrations are confined to the upper part. And you have these microvesicle type goblet cells, right? So this is a classical run-of-the-mill hyperplastic polyp, which you always see, right? Now, the second one is little tricky. Everybody got the first one as hyperplastic polyp, but here, see, not all of you did not think that this is, so you all thought that it is a different one, right? But here also see that it still has the serrations. If you go to low power, let me show you at low power. So low power view of the polyp is very important. See, I can turn it around. So maybe let me do it 360-degree turn. Now look at this, for example. So this is still a serrated polyp, right? You can go higher power, we will see the serrations. And here also you can see the serrations. But what is different here as compared to the previous example is that there are too many goblet cells, right? Lots and lots of goblet cells here. That's what might have thrown you a little bit off track, that you start thinking about other things, but still there are serrations, right? And again, as I said, they think of type of serrations. This is like, sawtooth-like serrations here. And here also the bases are not dilated. Before you say give a diagnosis of sessile serrated polyp or sessile serrated adenoma or sessile serrated lesion, you should look at the base of the crypts, right? So base of the crypts are not dilated and it is still a serrated polyp. So your diagnosis still is the same actually. This is also a hyperplastic polyp. So we will talk about these different types of hyperplastic polyps little later, but I want to show you some examples of different types of polyps first, okay? Next one, ascending colon polyp. And as I said in the beginning, don't think too much about the location. I mean, as residents, just think of the morphology. I think that will help you better. So what the histology looks like. Okay, so this is a polyp in the ascending colon, okay? So this one may be looking, so look at the low power view. So this one is very nicely removed, right? Okay, so you can see a pad of fat here and the whole polyp is here, you can see. Let's go to a little bit higher power. So here also you don't see the blue thing, right? So blue is for dysplasia, right? So there is no dysplasia as such. So this is not a tubular adenoma, isn't it? I know you know the diagnosis already, but I'm just trying to dramatize it a little bit, but I'm sure all of you got it. So still this is a serrated polyp, right? This is a serrated polyp. You have got goblet cells and you still see the sawtooth-like serrations. But what is characteristic here? See that there is something, right, which you did not see in the previous two examples. Okay, so here is this picture you keep in your mind, and let us ask you, so what is your most likely diagnosis? I have given you a few similar options, like you can see that B, C, D are somewhat similar, right? But looks a little bit different from each other. So I just want you to, that is the trick is, so just the trick is here, because between B, C, and D, why there are three different options? Okay, what do you guys think? Anyone? SSP, SSA, okay, E is traditional serrated adenoma, B is sessile serrated lesion. Okay, so there are different names here. Someone says SSL. Okay, that is good. So now let's go back to the picture, right? So this is one of these three. As you know, we saw hyperplastic polyp and we have not yet seen a traditional serrated adenoma. Okay, so I would say that let us call it, where did it go? Yeah, this is what you saw, right, in this picture. Okay, so this is a sessile serrated lesion. So why we call it sessile serrated lesion, we will discuss it soon. But here, just going back to the histology, you can see that again, this is a serrated polyp, no doubt at low power. But what is important or what is different in this serrated polyp compared to the previous examples is that these serrations are going all the way down, right? In hyperplastic polyp, you saw that the serrations are in the upper portion of the crypts only, or upper portion of the gland. But here, they're going all, you can see the serrations even deeper. That is one difference. The second difference is that you can see that there are dilated crypt bases. And you saw in the previous examples that the crypt bases were not dilated, but here they are dilated, and this one is asymmetrically dilated, right? And you see these dilated crypts all over, right? See, there are a lot of dilated crypts at the base, right? Isn't it? And this is kind of a transverse section, so you're seeing them like rounded glands, right? But you see a lot of dilated crypts, okay? So when you see dilated crypts and you have, like, serrations going down to the base, so your diagnosis is one of those, these three, whether it is a sessile serrated lesion, adenoma, or polyp. So I say that the answer is sessile serrated lesion. And why it is sessile serrated lesion? So we will come to that, okay? All right, so next one, this is a rectal polyp. If you have any questions in between, so please post your questions in the chat box so we can answer them later at the end of the session. That would be great. Okay, so rectal polyp, let me show you this one. As I say, the location, don't think too much, but still just focus on the morphology. So here, see, suddenly they look different. You see at low power that, this is different from the previous examples. So we don't have those really serrations that we saw. Okay. They're kind of pink. You see that there is a villus architecture. So I'm just going to the higher power. They are still looking like villi and they are very pink. Okay, keep an eye. So this is where the money is. I will just keep the picture here. Somebody, you guys have already started answering, okay? So these are my choices. So you know what it is, I guess so. So there are a lot of answers already which say that, oh, this is a traditional serrated adenoma. And I agree with you guys. So this is what you saw in that picture, okay? And this is traditional serrated adenoma. Now, going back to this is where all the morphologic features of a traditional serrated adenoma is. And again, I would say that don't think much about the location here. So this has a villus morphology, right? But you see that this is also a serrated polyp actually, but see the serrations are a little different. If you go to higher power, you can see that these serrations are different from the previous examples, and it is kind of a slit-like serrations. We will discuss that again. And at a lower power, this is pink, right? You have a pink eosinophilic cytoplasm. And also, if you go higher power, you see that there are pencillate nuclei, right? And on top of that, there are some ectopic crypts like this. So together, so this is a classic example of traditional serrated adenoma, and which we call it TSA, okay? So these are the common polyps that you saw. You saw two examples of two different types of hyperplastic polyp, right? And we will come to that soon. You saw a classic example of sessile serrated lesion, and I would emphasize that let's call it sessile serrated lesion. Why should we call it? So we will come to that. And this is an example of traditional serrated adenoma, right? So let us discuss them one by one. So colonic polyps, as you saw that this is how they look under the colonoscope, right? But when you look at histology under the microscope, so you see different pictures. Majority of them are epithelial, right? Okay, this is a tubular adenoma, or these are others. But you can also have mesenchymal polyps also. You can have spindle cell lesions, you can, like we will see soon. And this one has fat, so this is a lipoma, I guess. So they look like this under the colonoscope, but you have to be careful that under the microscope, they may look different, and you have to be careful when you make a diagnosis, right? So common ones are the epithelial polyps. As you saw that there are adenomas, and then serrated polyps. You saw the three examples of serrated polyps: hyperplastic polyp, sessile serrated lesion, and traditional serrated adenomas. So these are the serrated polyps. Then you have the mesenchymal polyps. We will see a few examples of mesenchymal polyps too. So keep them in mind. They are not that uncommon. Then there are some incidental findings. So you can find those within a polyp, but they are just incidentally found. You can call them polypoid incidentalomas or whatever. It is just a name, not in the WHO. Don't worry. So I feel that there are actually two eras of colonic epithelial polyps, if you think of it that way. So pre-SSAP, I will say why it is SSA/P. SSA means sessile serrated adenoma/polyp, or post-sessile serrated adenoma/polyp, because sessile serrated adenoma or sessile serrated polyp or lesion is not very old. It's recent. So before sessile serrated adenoma came, the life of the polyps kind of was very simple. There were not too many diagnoses. So you either had adenomas when something looked like this. So these are the tubular adenoma with low-grade dysplasia on these glands, which are hyperchromatic, you can see. And the second were the hyperplastic polyps. So everything else used to be called hyperplastic polyps. So whether you see this one, whether you see this one, so these would have been called hyperplastic polyps in that era, I would say. But then there was a very seminal publication in 2003 in which, so these group of authors, they described a group of polyps in the colon. So you can see here that these polyps are larger. These polyps are more on the right side of the colon, and they share classic histology. Like here, you have already seen that, you know that what they are talking about, right? So this is when the introduction of sessile serrated adenoma or polyp has come. This is not too long ago, like 20 years back, right? 2003. So after that, so things have become different, right? They have a different morphology, they have a different prognosis, and you now know that these sessile serrated adenomas or polyps are precursor to malignancy. So then the thing changed. So you now have conventional adenomas, and then you have the different sessile serrated polyps. Hyperplastic polyps are different. Sessile serrated adenoma/polyp, that is what it was called at that time. They were the second category, and the third category is traditional serrated adenoma. Okay, so these are the examples. We will come to them soon, right? So, but most recently, we also have this sessile serrated lesion, or WHO 2019 or the 5th edition. Okay. So serrated polyps are, you can broadly classify them into two groups. So there is that group with very little propensity for progression to malignancy. Those are the hyperplastic polyps. But the second group is, these polyps have propensity for progression to malignancy. So one is the sessile serrated lesion. I would always emphasize again today that this is what you call it. And the second is traditional serrated adenoma. These two lesions, you need to that is why you need to identify them. You need to diagnose them properly because they have progression to malignancy. So if you are getting it wrong between hyperplastic polyp and sessile serrated lesion, so that is dangerous, right? Because this is the pre-malignant, whereas this is not. So you cannot call one or the other, but they are very subtle sometimes to classify, and you do not have a marker to classify or differentiate hyperplastic polyp and SSL. So you have to rely on morphology quite a lot, right? But that's very important, isn't it? TSAs are easier to diagnose on morphology. You are not going to confuse TSAs with hyperplastic polyp, right? More unlikely. So hyperplastic polyps, briefly. So these, as you have seen that these are the polyps with serrated architecture without cytologic dysplasia. You don't see dysplasia in hyperplastic polyps, but they can harbor, or they often harbor BRAF or KRAS mutations. And on colonoscopy, they are usually very small sessile polyps, and more commonly or more often, hyperplastic polyps are on the left side of the colon. So in medicine and pathology also, there is nothing called specific. Okay, that is why I would use the word most common or predominantly. They are on the left side. There is nothing 100%, right? Always keep that in mind. Anything can happen everywhere, but some things are common in some locations. That is something good to know. As I said in the beginning, that for diagnosis of polyps, you focus on the morphology, not the location, but it is also important to know where they are usually located. Okay, so hyperplastic polyps are more common on the left side. And this is how they look like under the microscope, as you have seen. So you see these serrations, and you can do an inverted triangle, like the base of the triangle is towards the up, and then the apex is below. And also you see, as I showed you earlier, that the crypts towards the base, they are not dilated. They have a tapered ending, as you can see here, and you saw earlier too. So this is hyperplastic polyp. And there are three histologic types. There used to be three, but right now there are two. So one is this microvesicular type. The one, that is why you saw two different types, right? So if you go back to the picture here, what we saw, the first one is your classical microvesicular type of hyperplastic polyp. So this is your microvesicular type of hyperplastic polyp where you see microvesicles like this, right? Okay. And then the second example is goblet cell rich type of hyperplastic polyp. So these are very easily underdiagnosed, kind of. I will show you here because you usually think that when it is a small biopsy, you probably think that, oh, this is just a normal colonic mucosa, because how are you going to count the number of goblet cells, right? I mean, your number may be more than my number and maybe less, but keep it in mind that this is the other variant of hyperplastic polyp. If you have been given a biopsy, which was called a biopsy from a polyp on the left side, and you see something like that, like this picture, so this is your goblet cell rich type of hyperplastic polyp. You still have the serrations on the top, right? Okay. So there used to be a third variant, which was called mucin poor type, but as per the current WHO, so this one is very underdiagnosed and misdiagnosed. So this type is not there anymore. So you just have these microvesicular type and goblet cell rich type. Okay. But while you report it, you don't have to classify whether it is a microvesicular or a goblet cell rich type. They don't have like different prognostic implications practically. So you can just call it hyperplastic polyp and move on. Okay. But it is good to know. Otherwise, this second one, the goblet cell rich type, can be easily misdiagnosed. So now moving on to sessile serrated polyps or lesions or whatever. So why there is so much of an enigma about it? So what is there in the name? So when this paper was published in 2003, they called it sessile serrated adenoma. But now you know that in pathology, the word adenoma is always synonymous with dysplasia. But here there is no dysplasia, right? Why will you call it adenoma then? That is where the debate started that, oh, maybe this is not a good terminology to call it sessile serrated adenoma. So then, some people started calling it sessile serrated polyp. Then someone called it sessile serrated lesion. So that's why in the previous WHO in 2010, so it was called that, oh, you call it sessile serrated adenoma / polyp, so that, you keep both the things, because just to keep it simple. Well, and again, the debate continues that because there is no dysplasia on the top, right? So why you call it adenoma? So, but then came the most recent WHO in which they have renamed it or universally coined the term sessile serrated lesion. So I think as of now, so this is what we should uniformly accept it overall, that because it is very important to use uniform terminology. Otherwise, it can be very confusing. If someone says sessile serrated polyp, someone says adenoma, someone says lesion, then it is confusing also for the patients, for the treating physicians. So it is good to have a unified terminology. I really emphasize, because today we have an international audience, so we should better follow WHO and then call it sessile serrated lesion, because that's what it is called, right? So let us follow one guideline. So what is a sessile serrated lesion? Again, they do not have cytologic dysplasia, but important thing is that they are pre-malignant polyps, right? Which has excessive serrated architecture, and then they have BRAF mutation, and these polyps have high degree of methylation. So they are pre-malignant. You know that, okay? And sorry, this is not a microscopy. This should be endoscopy. So this is how the endoscopy looks like, or colonoscopy. So you see that these are flat polyps, and they can sometimes be large, like more than 1 centimeter. And these polyps have a predilection for the right side of the colon. So does that mean that they cannot occur on the left side? So we will come to that. But they are more common on the right side. Okay, keep that in mind. But again, for diagnosis of SSL, you focus on the morphology, not the location. So as you have seen that this has the serrated architecture, and we saw that the serrations go deep to the base of the crypts. And sometimes you have, or classically, you need to see dilated crypt base. And usually you see the asymmetric dilatation of the crypt base. And you need only one unequivocally altered crypt to make the diagnosis. You don't need a lot of crypts. And the size is also not a criteria. And again, neither size nor location is a criteria for diagnosing sessile serrated lesion. So just focus on serration going deeper to the base of the crypts, and asymmetric dilatation of the base of the crypt. That is what you need to make a diagnosis of sessile serrated lesion. So these are some pictures. You can see that SSL can look differently just based on how the dilatation is. Sometimes, it takes the shape of a boot, sometimes like an inverted T, it's like an anchor, or it's like an L, but don't go by the shape. You just need to focus on dilated crypt base. And these pictures show you that these dilatations are more asymmetric, okay? So this is what SSL looks like. But how do you differentiate from hyperplastic polyp? It's most common mimicker, right? Whether you call it hyperplastic polyp or sessile serrated lesion. Whereas you can rely on some simple criteria. For example, hyperplastic polyps, you see that the serrations are more on the surface or upper two-third, all right? Whereas in sessile serrated lesion, you see the serrations all the way to the base, here also, for example. Then in hyperplastic polyp, the basal crypts are not dilated. See here, they're all narrowed. And as you have seen before, that in SSL, you have dilated crypt base. These are the basic differences which will really help you. If you keep these in mind, more and more, you will be able to diagnose them correctly. Otherwise, you will always get confused. There is another subtle feature to differentiate these two, but which is hard to find, I would say. Many a times when you look at hyperplastic polyps, you will see some neuroendocrine cells at the base of the crypts. And these usually you do not see in the sessile serrated lesions. But I would say that this is a soft criteria to diagnose these two entities. So let's see this one. So here is a polyp in the hepatic flexor. So this is how the colonoscopy looks like. And you see this is a large polyp. It has two portions, as you can see here at low power. One area, it looks little bit, pale, and you have an area which is kind of dark, okay? So let's see a higher power of this. So you see here again, which is very striking, that you have an area here which definitely looks like a sessile serrated lesion. It is a serrated polyp, right? And then the serrations are going to the base, and you have dilated crypt bases. So this is SSL. But what about this? So this area you cannot call SSL, right? They look very much like tubular adenomas. So if you see something like this, let me see. So what would you call it? Anyone? I just showed you anyway what was the diagnosis. But anyone, would you like to give me a diagnosis for this? I'm looking at the chat box. SSL with dysplasia. Okay. Supriya says SSL with dysplasia. Umara also says the same, SSL with dysplasia. Tubular adenoma, TSA. Okay, cool. So there are two lesions here, kind of, right? Or two histology, not two lesions. It is one polyp. So that, see here, you can see that this is kind of an SSL at the base. It is this side, but it has actually become, dysplastic on this side, right? So this is your classic example of sessile serrated lesion with dysplasia. So that means that you caught it in the act, right? So as we said, that sessile serrated lesions are pre-malignant, isn't it? So because they transform into dysplasia, and they transform into high-grade dysplasia and, adenocarcinoma, and you have got this, both the thing happening in one polyp. So this is called sessile serrated lesion with dysplasia. This is another entity you can discuss more in detail. And when do you call it sessile serrated lesion with dysplasia? Earlier, they used to call mixed adenoma, right? Like, you have a hyperplastic polyp or SSL on one side, and that kind of looking like tubular adenoma on the other side. So some people used to be calling it like mixed hyperplastic polyp and adenoma, but these are BRAF mutated. And as you can see, that definitely they are prone to rapid progression to carcinoma. But something to keep in mind here is that according to the most recent WHO, or the current WHO that you are following, we are not supposed to grade the dysplasia in sessile serrated lesion with dysplasia. We are just supposed to call it SSL with dysplasia, because the reason is that whenever you see a lesion which has both SSL and dysplasia, that means that it is already an advanced process, right? The lesion is already progressing, and you don't need to now call it high grade or low grade. So these patients need to be closely followed up, right? Okay. So in fact, so this is where you see SSL moving to dysplasia. But let me show you this example where you see all three processes. Look at this. So you see here there is a sessile serrated lesion, right? And here it is turning into dysplasia. Like I don't have a higher power, let me show you. And then here you see mucinous adenocarcinoma. So all three happening in this one classic picture, right? Sessile serrated lesion with dysplasia and adenocarcinoma, right? And so this is a higher power. You can see the sessile serrated lesion on the right, and then it's becoming a little bit dysplastic, okay? And this is what you can see. But here, if you do mismatch repair, you can prove it. So you see that this tumor, this is from the same picture. You see that, there is loss of MLH1 and PMS2. This highlights the importance of actually diagnosing sessile serrated lesion. Why it is so important to diagnose sessile serrated lesion? Okay, because they are a pre-malignant. So practical points. So most hyperplastic polyp on the right side of the colon, do they exist? So that is something you will always remember, that, I mean, it is difficult to call hyperplastic polyp when you have a biopsy from the right side. So because most of the time, sessile serrated lesions are on the right side, and as you have seen that these are pre-malignant, right? So if you are underdiagnosing sessile serrated lesion, so that's not the right thing to do. Maybe like, you are not doing it right, because if you call it hyperplastic polyp on the right side, that means that you are giving a, clean passage for the patient that there is no problem, isn't it? But you should not be missing a sessile serrated lesion. So to rule out a sessile serrated lesion, the first thing to do before you give a diagnosis of hyperplastic polyp on the right side is that get additional levels. Make sure that you are not missing a sessile serrated lesion, because in your first level, you may not see all the features of a SSL. So maybe like, after you get levels, you will see classic features of SSL. And as you have seen that you just need one dilated crypt. You don't need all the crypts to show features of SSL. So you probably would be lucky when you get levels, and you would probably be able to call it SSL and then move on. But if after additional levels also you do not see any classic features of SSL, but you see serration, are you still calling it hyperplastic polyp? It is debatable, but I prefer practically that I would call it serrated polyp, not otherwise specified, and write a note. I hesitate to call hyperplastic polyp on the right side, even though it can be, histologically classical after you get the level. So call it sessile serrated polyp, not otherwise specified, and write a note. So I would write that this polyp does not fulfill the histologic criteria for sessile serrated lesion. However, considering the right side location, the patient may be closely followed up, because sometimes it is a flat lesion. When the biopsy is taken from the polyp, you may not get the exact area where the morphology is. So it's better to leave it like that and move on and ask them to follow up. I think that's what I personally do, but there may be, other practices. So there is also serrated polyposis syndrome, and this is rare when you have more than 20 serrated polyps of any size throughout the colon, and at least 5 proximal to sigmoid colon with 2 or more than 10 millimeter. These are some like criteria for diagnosing serrated polyposis syndrome. Okay. So now moving on to traditional serrated adenoma, which is the other type of serrated polyps. These are the rarest of the serrated polyps, and they are more common in the left side, that is rectum or sigmoid colon. So does that mean that they cannot occur on the other side? Of course, they can occur, but they are more common on the left side of the colon. So you can see KRAS mutation and also BRAF mutation in traditional serrated adenomas. And the problem with TSA is that they are also pre-malignant, so you got to diagnose them correctly. So histology, you saw that what is the classic histology of TSA? And it has this villiform architecture, slit-like serrations, eosinophilic cytoplasm, and the presence of ectopic crypt. Let me show you this picture. So this is your villiform architecture. That's why you sometimes at low power, you see that this is like a villus adenoma. That would be the easiest differential for a TSA, but because it is also villus. But if you look at the low power, you see that they are very pink, eosinophilic cytoplasm as compared to a villus adenoma, which would be blue. Like this is more pink. And here you see the other thing is that they have very pencillate nuclei. That is very, very classical of TSA. Now, the other easily identifiable histology of TSA is the type of serration. So if you see the type of serration in TSA, they are different from hyperplastic polyp. So look, you can see the hyperplastic polyp here. So they are showing sawtooth-like serrations, right? But in TSA, they have slit-like serrations, isn't it? That is very, very different and easily perceptible. So this is TSA and this is hyperplastic polyp, okay? And another criteria, which is the hallmark of diagnosing TSA, but again, this is not specific. So ectopic crypt foci. So see that these are some ectopic crypt foci you can see within the epithelium. And this you see very, very frequently in TSA. So if you combine these all morphologic features, so you can actually, there is no definite criteria that you need to have either of these, that when to call it TSA. So basically, it's a combination of all four. When you see all these four in a particular polyp, you can easily make a diagnosis of TSA. So none of them, these four are specific. So, but keep that in mind. But you can make a diagnosis when you consider all together. So this was a paper we wrote a couple of years back about morphology and molecular alterations in TSA. So maybe someone of you may be interested and look it up. So to summarize serrated polyps and talk about the serrated polyps most according to the recent WHOs, you have hyperplastic polyps. These are of two types, right? Microvesicular or goblet ciliaris. Then you have sessile serrated lesion without dysplasia and with dysplasia. And then you have the last one is traditional serrated adenoma. Okay. But why you need to diagnose them? The important thing is that how they are followed up. This is a very useful table to keep in mind for our residents, is that if you give a diagnosis of hyperplastic polyp, the follow-up is for 10 years. So sessile serrated polyp or SSLs, it depends on the size, as you can see here, and the number. So they have different follow-up period. So if it is bigger size, more than 10 centimeter or more than 10 millimeter, so this is 3 years. Or SSP, if it is with dysplasia, they have a 3-year follow-up. So that is the reason why you actually need to give a proper diagnosis so that you know that how these patients are followed up. Like, see, if you call it SSP, so, I mean, it is like, closer follow-up. So, but if you say HP on the right side, so this patient will not be followed up for 10 years. So then, if something goes wrong in 10 years, then you are missing it, right? That's why on the right side, I am very careful not to call hyperplastic polyp and let the patient have a closer follow-up, not to let go for 10 years, okay? So let's move on. I want to show you a different polyp, which is in the descending colon. And let's see what it is. So we are moving on from these type of polyps. So I will show you this one, which is a little different. Look at this. So this is a low power view of this polyp here. So if you see that this is not a tubular adenoma, right? Okay, there is no dysplasia. This is not a, a hyperplastic polyp or something that we discussed. But let's see higher power. These glands look a little bit dilated, right? I think there is some lag. Let me show. Sorry about that. They're taking a lot of time to. So anyway, so you saw a little bit, right? Like, I mean, at low power at least. And based on that, let me ask you. So these are your options. So what do you think? Inflammatory polyp, okay. All right. I agree with you guys that this is an example of inflammatory polyp. So inflammatory polyp, I don't want to go further, but remember that this is not a hyperplastic polyp or this is not a tubular adenoma, right? You don't have dysplasia here, and you have a lot of, lamina propria dilatation. There is dilated glands, edematous lamina propria, inflammations around. So this is an example of your inflammatory polyp, okay? Just don't call them by other names. So the next one is a polyp in jejunum. So see, jejunum is not a very common location for polyp, right? But if you have a polyp in jejunum, so okay, so you better be careful. So let me show you, what do I have? Okay. So see this. So this is a polyp in jejunum. A lot of things are happening here, right? Uh, it's very busy. This is a higher power. Let us see. I think it's not projecting well, because it seems like it is faded. All right. So you see it here, right? Isn't it? It's very, very classical. There is no dysplasia. Let's see what we want to talk about. So you already gave your diagnosis. I am seeing it. So Peutz-Jeghers polyp is the diagnosis, correct? Okay. But there is no choice here. I have not given a choice of Peutz-Jeghers polyp, right? So then why will you call it? So yeah, okay, C is hamartomatous polyp. So what is the difference between a hamartomatous polyp and a Peutz-Jeghers polyp, right? So we will come to that. So before we move on, so you see that, let's go back to the slide. So this is a classic example of a hamartomatous polyp, right? And you see here that you see a lot of glands, but how these glands are divided, you see this arborizing stroma, right? There are these smooth muscle bundles which are going in between the glands, right? Okay. But somehow this leg I'm not being able to take care of. I'm sorry about that. You can see these muscle bundles, right? So, and there is no dysplasia here, but this leg is not going. Okay. Uh, so I said that this is a hamartomatous polyp and not a Peutz-Jeghers polyp. These are both synonymous, but as residents, I would say that it is important to know correct terminology. So Peutz-Jeghers polyp is not a histologic terminology, right? You can have, what is a hamartoma, right? Hamartoma means that when you have aberrant proliferation of tissue which is indigenous to that site, that is a hamartoma, right? So here in this polyp, all that you see is that, you have these glands and you have a stroma which is proliferating a lot, but it is indigenous to that site. So this is a hamartomatous polyp, because, I mean, if you make a diagnosis of Peutz-Jeghers polyp on histology, as pathologists see, you are not going to get the patient's clinical symptoms or clinical features immediately. You just get a polyp, and suppose you call it Peutz-Jeghers polyp, right? And this patient is not a, patient with Peutz-Jeghers syndrome, because Peutz-Jeghers syndrome is a constellation of different phenotypes, right? You have this pigmentation, these, that, and polyps are part of Peutz-Jeghers syndrome. So if you call it Peutz-Jeghers polyp, you might be labeling a patient as Peutz-Jeghers syndrome when the patient may not actually be a patient with Peutz-Jeghers syndrome, right? Okay, because what is Peutz-Jeghers syndrome? So these patients usually have mutation in STK11 gene, and there are low risk of malignancy. And there are some associations with Peutz-Jeghers syndrome, which as pathology residents, you need to know. Let me tell you quickly. For example, there is an ovarian tumor, which is classically associated with Peutz-Jeghers syndrome. And this is the classic histology of that ovarian tumor. Okay, and I'm sure many of you know what it is. So let me give you some choices. What is this one? Anyone? So already C is the right answer. You guys are great. So this is sex cord tumor with annular tubules, which again, it can be sporadic, but classically you can see in patients with Peutz-Jeghers syndrome. There are a few other lesions which you see in patients with Peutz-Jeghers syndrome. So one, you saw it, right? There is another one here, which you see in the cervix. So if you see this lesion in the cervix, in a patient with Peutz-Jeghers syndrome. So what is the diagnosis? Anyone? Can you type it in the chat box? Hmm. I don't see anything. Okay. So this is an example of what is called your minimal deviation adenocarcinoma in the cervix, which used to be called adenoma malignum before, not anymore, right? Yeah, see, adenoma malignum is an older terminology. As I said in the beginning, that know the terminologies which are current, okay? So that's very important. And this is what you saw, the hamartomatous polyp. I do not like the name Peutz-Jeghers polyp, as you said, but you can use it. But the reason I told you. Okay, so these are the things that you see in patients with Peutz-Jeghers syndrome, right? Okay, let us quickly show you another mesenchymal polyp, or like, let me show you this one, polyp in the hepatic flexor, what it looks like. 1 second. This is a good mesenchymal polyp to know, but I hope I don't know about the lag thing, which is not helping. Okay. Yeah. So look at this polyp. So we have seen a lot of epithelial polyps, but what about this one? This does not seem like an epithelial polyp, right? A lot of activity is happening in the stroma here, right? Which looks very cellular. And you can already see at low power some blood vessels. I hope I can see it. Not really. I'm sorry, I don't know what is happening here. It's not getting away. Okay. All right. So what I was trying to show you at low power is the polyp which is in the colon with lot of vessels. And if I tell you that these vessels have, concentric lamellation, some spindle cells around the vessels, and there are a lot of eosinophils in the stroma. And many of you have already given me the diagnosis, and of these choices, so definitely the diagnosis is inflammatory fibroid polyp, right? You guys are right, okay? So inflammatory fibroid polyp, let me ask you this question. So which of the following mutation is common in inflammatory fibroid polyp? Anyone? PDGFR alpha, correct. So PDGFR alpha mutation is observed in inflammatory fibroid polyp. So that is why IFP, so here it is. This is the classic histology for those who have not seen it before. You see this like, blood vessels with concentric spindle cells around the blood vessels, and there are a lot of eosinophils in the stroma, and they are usually located in the submucosa, okay? And this is a benign lesion. So you call it a tumor because they have PDGFR alpha mutation. Most commonly, you see them in the stomach, and you can do CD34 to highlight the spindle cells, not just the blood vessels, but these spindle cells can be highlighted by CD34. Okay. I think that we already are like running short of time, so I would leave it for some questions. If you have, I would skip a few more that I wanted to share, but let us summarize quickly. So to summary, what I wanted to show you is, so there can be different types of colonic polyps, right? Isn't it? You saw that most of them are epithelial polyps. You saw hyperplastic polyps. You saw sessile serrated lesion. You saw traditional serrated adenomas. So not all are the same, right? And as I emphasize that you should, as residents, lay importance on the morphology criteria and don't get biased by the location. So locations is important, as you have seen that. Oh, you want me to continue? But it will go beyond 1 hour. Is it okay?
Yes, it is okay if you have time and if you want to
Yeah,
continue,
I
you can
can
continue.
finish it. I can continue. Okay. Yeah.
Okay, yeah,
All right.
you can finish.
Yeah, okay. So these are very, I would finish them quickly then. So mesenchymal polyp, there are some incidental findings, or like, this is again not a WHO terminology. You can call them incidentalomas, but this is not WHO, okay? Uh, but I strictly follow WHO because I don't want to come up with some weird terminologies. Okay, let's look at this. So this one, see here, this seems like on this side, it is a probably serrated polyp, okay? But what I want you to focus on is this area. Look at this. Here you have the dilated lamina propria, right? Or expanded lamina propria. And in this lamina propria, you have some spindle cells, right? But let me see if my lag is getting better. probably not. But you can see some like, I mean, take my words that you have got, very bland looking spindle cells here. Okay. And that is all you see. But in the background, there is actually a hyperplastic polyp or a sessile serrated lesion here. Okay. So, but because we are focusing on the incidental finding, so what is your diagnosis then? So if you have these choices, someone says, Supriya says schwannoma, C, perineurioma. Okay. So this is a classic example of actually, so this is what you saw, right? So you have the lamina propria, which is expanded by very, very monomorphic spindle cells. And you see a background of hyperplastic polyp, maybe, right? So this is a classic example of perineurioma, which is incidental, absolutely. And they're often associated with serrated polyps, but you can also find them in, I mean, colonic mucosa, which is biopsied not for a polyp. If you want to do an immunostain, you can try EMA, GLUT1 or Claudin-1, which would be positive. S100 is negative. That is something that you should keep in mind. But I don't think that you should waste your immunostain to diagnose this. So if you see this, you can call it perineurioma, and maybe you just do S100, because if it is S100 negative, you can call it perineurioma. So why I am saying S100 negative? Because there is a closed differential which looks very similar like this, right? So here also you can see a polyp and you have some spindle cells, right, in the lamina propria, very monomorphic still. But these are S100 positive, strongly S100 positive. So when you have S100 positive cells, which look very much like a perineurioma, so what's your diagnosis? So go back to the same choices. Definitely this is not a perineurioma now. What is your diagnosis then? B, schwannoma, Verruca body schwannoma, okay. But like, yeah, the proper terminology is mucosal swan cell hamartoma, because these are small ones. Like schwannoma will be a bigger lesion, okay. So mucosal swan cell hamartoma will be the correct terminology for this, right? When you see spindle cells which are S100 positive. So that's why if you see spindle cells like this, so better just do a S100 if it is negative. Most of the time, these are more common, like perineurioma, but S100 if it is positive. So this is the mucosal swan cell hamartoma. So these are benign and again incidental findings, and more commonly in the distal colon, and they do not usually have any syndromic association. So like, I mean, very inconsequential, but still these are subtleties. So it's good to diagnose them. So sometimes, rarely, you can find some weird things which will present as polyp, because as you know that polyp is just that terminology for anything which is protruding towards the lumen, right? That is what is a polyp, right? But so that's why you have to keep in mind that what is inside the polyp, right? Not all polyps are the same. So this is a 10 millimeter polyp in the rectum. You see that there are some polypoid projections, but look at the histology. See this. This is again something weird. You have this colonic type mucosa on the left, but on the other side, this one looks a little bit different. So let us see how it is. Let's go to higher power. So this is like a colonic mucosa. So what is on the other side? At this power, can you know? What is it? What type of mucosa it is? I'm asking you without giving you choices. What do you think? Gastric. So pyloric mucosa, pancreas-like. Yeah, see, this is different, isn't it? At least you know that this is not colonic mucosa. And why I am showing you this particular picture is that, so this, you can see the transition, right? You have the same polyp, you have nice colonic mucosa on one side, and which is transitioning into gastric type mucosa on the other side. Because if you just see a small biopsy which is showing gastric type mucosa in a polyp, you might think that, oh, this is probably a contamination, right? Because maybe like they use the same forceps to take a gastric, what's it called? Biopsy, and then they put it in the colonic or rectal biopsy. So, but this one tells you that, hey, this is actually a gastric type mucosa appearing in the same polyp, right? So let's see, then what do you call it? This is gastric mucosa, and you can see another picture. You see the transition from here So this is oxyntic type glands that you can see here, isn't it? And this is gastric foveolar epithelium. So how will you call it diagnosis then? There has to be a terminology, right? As I said in the beginning, that we should use proper terminology. What would you call it? D is gastric heterotopia, gastric contaminant. Okay, not a pylori gland adenoma. Okay, so this is a classic example of definitely gastric heterotopia, right? So gastric heterotopia meaning like, yeah, of course you are seeing. So this is the other word, like the difference between heterotopia and hematoma, right? Hematoma is exuberant proliferation of tissue which is indigenous to that site, right? Heterotopia or ectopia is when you have abnormal tissue at an abnormal location, right? You have stomach in the colon now, right? You know that you can see pancreatic tissue somewhere else. Pancreatic heterotopia is there. You can see gastric heterotopia and pancreatic heterotopia sometimes in what is that called? In many locations, right? I mean, but that's the difference between heterotopia and or ectopia and the uh, hamartoma. So that's why you should know the terminology as well. And gastric heterotopia in the colon, it's uncommon, but you should keep that in mind. And basically, like you can actually call it outlet paths. I mean, there is an inlet paths, right? When you see gastric heterotopia in the proximal esophagus, you can, if you see proximal esophagus gastric heterotopia, you call it inlet paths. But it's just a funny way to call it, that you can call it an outlet patch. Actually, when I was a fellow, so we wrote this paper with Dr. Montgomery, and we talked about gastric heterotopia, and we called it outlet patch, and we had a lot of cases. I think 33 cases of gastric heterotopia in the colon, and some of them can be associated with, in malignancy also. But I would say that just to keep that in mind, that this is also something that you can rarely see. So to summarize, again, uh, just that colonic polyps, you can see that they are different. You can have epithelial polyp, you can have mesenchymal polyp, you can have the subtle ones, and you saw that sometimes you can have weird things like a gastric mucosa there, right? So today we have not even discussed about the malignant tumors. We have not discussed about the metastatic tumors which can form as a polyp, right? You can have a polyp which is probably a metastatic lesion from somewhere, right? We have not talked about that. That's a different entity. So I would again emphasize that you rely on morphology. That should be the cornerstone of diagnosing an entity correctly. So if you think of the proper morphology criteria, so then definitely you would be able to diagnose them correctly. And important to use uniform nomenclature. As you saw in the case with sessile serrated lesion, which has evolved. We don't know what will it be called in the next WHO. Anything can change, but we use evidence-based practice, right? If all our colleagues in different other branches of medicine use evidence-based practice and the current guidelines, so pathology should not be different too. That is what I feel, that you follow, or we should follow WHO guidelines, and that is how we should call them. And same thing about the Peutz-Jeghers polyp. Yeah, of course you can call it Peutz-Jeghers polyp, but we are making a, remember, histologic diagnosis. Our diagnosis should be based on what you see under the microscope, because there is nothing called Peutz-Jeghers under the microscope, right? What is Peutz-Jeghers? There's nothing Peutz-Jeghers under the microscope, but yeah, you can call it a hematomatous polyp. That's what, then that is safe for you, because you are not going to make a wrong diagnosis of Peutz-Jeghers polyp in a patient who is not a patient with Peutz-Jeghers syndrome. So you would be safe if you just call it hematomatous polyp, and you can write a comment that this patient, this type of polyps are commonly seen in patients with Peutz-Jeghers syndrome. The patient may be followed up. Maybe you are the first person to make a diagnosis of Peutz-Jeghers polyp or suggest a diagnosis of Peutz-Jeghers polyp in that particular patient, right? But you may be the person who is wrongly calling also a patient with Peutz-Jeghers syndrome just by giving the wrong name when the patient is not, and it is just a sporadic polyp, right? So the last one, you should know the common polyps, like the hyperplastic polyp, the sessile serrated lesions. Yeah, definitely you should know how to diagnose. Traditional serrated adenomas are rare, but also be aware of the other types of polyps. You saw inflammatory fibroid polyp, but don't confuse inflammatory polyp with tubular adenoma, right? And be careful or just be aware of the subtleties, like the one you saw. You saw a perineurioma, you saw a Schwann cell hematoma, and sometimes you will find weird things like a gastric heterotopia. It's good to know. Like, as there is a common saying that uh, eyes do not see what the mind doesn't know. So you have to know first before you can recognize. And in the era of AI, which is moving very fast, so you got to be smarter than the AI, right? Isn't it? I mean, you got to be smarter, and then you do not want to let AI overpower pathologists, right? That's not going to happen. So, but it's good to be smart all the time, and then know your pathology and know your polyps, isn't it? But lastly, so you just need to enjoy them. So, but of course, this is a picture I generated using ChatGPT. So they can generate pictures nowadays. See? So, I mean, AI is coming. Definitely, we need to embrace new technology, but be smart and have our own knowledge first. Thank you. And if you have any questions, I am happy to take them.
Yeah. Thank you, Dr. Rifat. It was a very well explained talk, and you explained it in a very simple way. So if you have any questions, you can write in the chat box.
What is the difference between heterotopia and metaplasia? I saw a picture. So that's a very good question. When do you call it metaplasia and when do you call it heterotopia? So the simple answer is, what is metaplasia? So metaplasia is if you go back to your Robbins or any other book that you follow, so metaplasia is when one type of epithelium changes to another type. That is metaplasia, right? Only the change in epithelium, right? You have squamous metaplasia in the cervix. Just the epithelium is changing. You have squamous metaplasia in the bronchial glands. Just the epithelium is changing. You have intestinal metaplasia in the lower esophagus, right? In Barrett's. Just the epithelium is changing, right? Heterotopia is when you see the whole mucosa. So like you have gastric heterotopia means not just the epithelium. You use the word heterotopia only when you see the epithelium along with the submucosal glands together. That's what is gastric heterotopia. Pancreatic heterotopia, you see the pancreatic acini and everything like together, you can call it pancreatic heterotopia. It is sometimes more of a semantic, like, I mean, it doesn't have a prognostic significance, but I believe that it is good to know what is a metaplasia and what is a heterotopia. Yeah. Can you please show ectopic crypt foci on picture again? So I can show you quickly. 1 second, okay?
No.
Let me show you an ectopic crypt. Yeah, here. But again, I don't know if I'm sorry, I think that's a problem now. Wait, let's go back to this picture. Here also we can, 1 second. See the ectopic crypt, I will go quickly. Where did it go? Here, okay. So these are the ectopic crypts. You can see here, 1 second. So when you see that, so within the epithelium, you can see some invaginations like this one, right? So these are invaginations within the epithelium, which is kind of ectopic. Like here, it is more pronounced. See? So these are the examples of ectopic crypt that you see classically in traditional serrated adenoma. But this is not specific. Keep it in mind. This is a histologic hallmark of TSA, but this is not specific that, oh, you need ectopic crypt to diagnose TSA. No, it's not like that. Okay. Any other question?
So there was a question like juvenile rectal polyp. Do we also call it hematomatous polyp?
Good question. So that is another entity that so juvenile polyp, right? A polyp is juvenile, not on histology, right? There is nothing called juvenile on histology. It's same like, so the histology is an inflammatory polyp, isn't it? Right? So you call an inflammatory polyp a juvenile polyp when the patient is young, right? In a young patient, if you see this polyp, you call it a juvenile polyp, right? And because there is also juvenile polyposis syndrome, right? Where you see same type of juvenile polyps, like, I mean, lots and lots of them. But the histologically, it's an inflammatory polyp. So that is why, again, I would suggest that as residents, do not call it juvenile polyp on a slide. Call it inflammatory type polyp or inflammatory polyp, because that is the histology. Because the same polyp you can even see in patients with ulcerative colitis. Ulcerative colitis patients have those pseudopolyps and inflammatory polyps. So just by the age, if you call it juvenile polyp, and like when you are on a busy day, you see a polyp like this, and you did not think of the patient's age, and you call it a juvenile polyp, who is a 67-year-old patient, or maybe the patient who came with, ulcerative colitis. So you will get it wrong, right? That is another word, like juvenile polyp, stay away. I will suggest that just as residents, like, it's a good practice to know your proper, histology. Yeah. What else? Any other question? No, right?
Yeah, we don't have any other questions.
Okay. So in that case, thank you so much again. Thank you for the opportunity. Thank you, Hassan. It's always a pleasure talking to you, and thank you for the invitation. And thank you all for joining today, and wish you all the best. So again, as Hassan mentioned in the beginning, that we have PathCast lectures. I think that PathCast lectures are very useful. There are a lot of PathCast lectures. You can go to the YouTube channel on PathCast, and but there are a lot of lectures for residents, so you can be definitely benefited by them. I strongly suggest, not because that I run them, but I think I do not have a single lecture there. So these are all delivered by very renowned people. So yeah, I think you should follow them. It would be very helpful. And good luck. I mean, I wish I could post you a link for the PathCast YouTube channel, but you can find it on YouTube or Facebook, and even now we have on Instagram. We have an Instagram account on PathCast, so you can follow it there also. And we have tried to make some small reels so that you can learn some simple pathology in 1 minute. Okay.
Okay.
Thank you,
Yeah.
guys. Bye.
Thank you. It was a pleasure having you, Dr. Rifat. And I still remember, like, when you started PathCast, first you started it on Twitter Periscope, you and Amelia, and
Yeah.
then you shifted on Facebook Live and then YouTube Live, and now you even have a channel on a WhatsApp. So we can also get your updates on your WhatsApp channel. So
Yeah, you can join WhatsApp. Actually, there is a WhatsApp channel. Exactly. There is a WhatsApp channel. So you can join the WhatsApp channel as well. And this is the link for the, what's it called? A YouTube channel that I am posting on your chat box, because I think all the lectures definitely you will get on the YouTube channel. So that would be the easiest. So you will find all of them there. Okay. Thank you again.
yeah, thank you. It was a pleasure having you.